A very good afternoon to everyone. On behalf of Walter Kluwer, a warm welcome to our speaker and attendees of this anatomy webinar under our MedicalEdge series. Our topic today is brachial plexus. We have three major learning objectives from this session. Describe the location and formation of brachial plexus, describe the branches of brachial plexus, and describe the area supplied by the branches of brachial plexus with applied aspects. Our speaker today is none other than Dr. Kumar Satish Ravi, who is Professor of Additional Anatomy. He is the Editor-in-Chief, National Journal of Clinical Anatomy, Additional Proctor and Assistant Controller of Examination. He is ex-Sub-Dean Academics and Assistant Dean Academics, All India Institute of Medical Sciences, Rishikesh. We also will be taking all questions at the end of the webinar, and I request you all to please post all your questions in the Q&A panel of this event. We'll try to address the maximum questions possible. Please also provide your valuable feedback via link which we will post in the chat section of this webinar. We now begin our session and I hand it over to Dr. Ravi and I request him to please start sharing his screen.
Am I audible, sir?
Yes, sir, you are, sir. Please go ahead, sir.
So I'm Dr. Kumar Satish Ravi, working as Additional Professor in the Department of Anatomy at AIIMS Rishikesh. So first of all, I would like to congratulate all the medical students who have joined their dream course because of their hard work. To be a successful doctor in the future, it is no doubt that your basic foundation in the medical subjects should be strong. I remember when I was in the 10th class, our teacher used to say that once you perform well in the board examination, your career is set. Similarly, even in the 12th class, when we were appearing for the board or during this 12th class, the same thing I was told by our teacher, that once you will perform well in the 12th examination, your career will be set. Later on, again, the same thing, we were told that once you will clear the medical entrance examination, you will become a great doctor, right? But to be very frank, I must tell you, the real journey towards your profession begins now. Not that just cleared your medical entrance examination and you have become a great doctor. It's nothing like that, right? So you will have to work hard, and every week, or you say almost every month, you will be appearing in one or the other examination. So I'm not scaring you, but just making you aware that medical profession, you will have to work hard in this profession. So today I will be discussing about this brachial plexus, not just as an anatomist, but as the editor of a globally recognized book, The Snail's Clinical Neuroanatomy, which is being published by this world's one of the best publisher, you can say, the Walter Kluwer. I thank Mr. Ravi Shukla and Walter Kluwer team for organizing this MedicalEdge series for enlightening the medical students. And I also thank the Walter Kluwer team for inviting me to deliver this lecture. This session mainly concentrates on the very basic information about the spinal nerves. We will discuss about the brachial plexus and their applied aspects. So without much delay, we'll start the session. So these will be the learning objectives. By the end of the session, you should be able to describe the location of the brachial plexus, the formation of the brachial plexus, the branches of the brachial plexus, and the area supplied by the branches of the brachial plexus. Now, whenever we are studying any anatomical structure, or you say the reason, first thing which comes to our mind is why we are studying this topic. What is the importance? Because when you will be dealing with the patient, no patient will come to you for learning anatomy of brachial plexus or any of the structure or organs you say. So for that, would like to begin this brachial plexus by a case scenario you can see over here, the case goes like this, that a baby boy weighing 4.2 kilograms was born to a primigravida. Primigravida, it means a woman who is pregnant for the first time. So the labor was spontaneous by a rupture of membranes, but the fluid was meconium stained. The vaginal delivery was assisted with the low forceps, but the extraction of the baby became difficult due to shoulder dystocia. Now, the shoulder dystocia, it means when the size of the baby is bigger and the pelvis is small, then it is difficult to deliver the baby. That condition, when the body of the baby is stuck during this delivery, that condition we called as the shoulder dystocia. So a left Ubbs palsy was immediately apparent with no deltoid and weak biceps function, you say. By 6 weeks, there was remarkable improvement, and by 3 months of age, recovery was complete. So this is how the baby of the, you say, with Ubbs palsy presents. You can see over here, this is the condition you can see over here in the slide, Ubbs palsy. So this is how the baby presents with the Ubbs palsy. So to understand how the deformity was caused, means that Ubbs palsy, and what will be the treatment, how this patient, this baby will be treated, it is essential to know the site of the lesion and what are the nerves which get injured, or what are the nerves which are involved in this clinical condition. There lies the importance of knowing the anatomy of the brachial plexus. Now, when we see over here, before studying this anatomy of the brachial plexus, we see how our typical spinal nerve is formed. And when we talk about the spinal nerves or the cranial nerves, when we see this cranial nerve, there are 12 pairs of the cranial nerves. Accordingly, there are 13 pairs of the spinal nerves. And these spinal nerves are named after the group of the vertebra, which between which these spinal nerves emerges. So over here in this diagram, you can see this is the spinal cord, and there are the different regions. This is the cervical region. Over here, we have the thoracic region. Then we have the lumbar region. And accordingly, we have the sacral and the coccygeal region. So as I said that we have 31 pairs of the spinal nerves. You will find 8 pairs of the cervical nerves, that is from C1 to C8. Accordingly, we have the 12 pairs of the thoracic nerves that extends from T1 to T12. Then apart from that, we have the 5 pairs of the lumbar nerves that is from L1 to L5. Accordingly, we have the 5 pairs of the sacral nerves that denotes by, you say, the S1 to S5. And we have 1 pair of the coccygeal nerve, which is located at C0, we say. Now, when we talk about this spinal nerve, this spinal nerves attached to the spinal cord via roots. Over here in this diagram, you can see these are the ventral roots, and over here, these are the dorsal roots. This is the section of the spinal cord. Over here, you can see this is the gray matter. Over here, we have the white matter. This you can appreciate is the anterior horn, and posteriorly, you have this posterior horn, which is slender in shape. And between this anterior horn and the posterior horn, you can make out in this diagram, this we have is the lateral horn. So this is all about the gray matter. When we see this ventral root, it consists of the bundles of the efferent fibers which arise from the nerve cells in the spinal medulla. Over here, you can see these are the ventral roots, and over here you have the spinal medulla. When we talk about this dorsal root, it consists of the afferent fibers which arise from the cluster of the nerve cells in the spinal ganglion on each dorsal root. So each of these ganglion cells send one process into spinal nerve and another into the spinal medulla through this dorsal roots, you say. These two roots unite at the ganglion in the intervertebral foramen to form the trunk of the spinal nerve. Now, this spinal nerve, if you see, this spinal nerve will divide into the ventral ramus and a dorsal ramus. And accordingly, if we will see over here, this small dorsal ramus passes backwards, and the large ventral ramus will pass laterally, and then further it will divide. We can see in the further diagram over here. If you can appreciate over here, you can see these are the ventral roots and these are the dorsal roots. These ventral roots and the dorsal roots will unite and will form the spinal nerve. These spinal nerve will further divide into the dorsal ramus, which is going posteriorly, which is smaller in shape over here, you can see. And if you can appreciate over here, this is the ventral ramus, which is coming anteriorly, right? So what I wanted to say over here, that we have two roots. One is the ventral root, another is the dorsal root. The ventral root and the dorsal root will unite, will form the spinal nerve, and these spinal nerve will further divide into the dorsal ramus and the ventral ramus. So when you see this rami, these rami are the lateral branches of the spinal nerves. These rami contain both sensory and the motor neurons, which are further divided into two major groups. As I said, we have the dorsal ramus, which these dorsal ramus innervates the dorsal region of the body, that is the posterior aspect. Whereas when you talk about this ventral ramus over here, these are larger, and these neurons innervate the anterior aspect or the ventral regions of the body, and these ventral ramus, that is the braid together, will form some of the plexuses. These are the 5 plexuses we will see over here. So soon after these formation, each ventral ramus receives gray ramus communicants from the corresponding sympathetic ganglion. And when we talk about the thoracic and the upper 2 or the 3 lumbar ventral roots, and rami contain an additional group of the myelinated fibers that we say the white rami communicants. So we will see over here in the next slide. That's what I was talking about, this nerve plexuses. So when we say this spinal cord, there are, I said, the 31 pairs of the spinal nerves are there, right? And I said that in the different regions, like we have the cervical region, we have the thoracic region, we have the lumbar region, we have the sacral and the coccygeal region. So when, apart from this T2 to T12, when we say the rest of these ventral ramus will form some of the plexuses, right? And these plexuses are the branch, means the branching network, and these are the cervical plexus, the brachial plexus, which we'll be discussing today. Then we have the lumbar plexus, the sacral plexus, then finally we have the coccygeal plexus. When we see this cervical plexus is formed by the ventral rami of C1 to C4, whereas the brachial plexus is formed by the ventral rami of C5 to T1, whereas the lumbar plexus is formed by the ventral rami of L1 to L4, whereas the sacral plexus is formed by the ventral rami of L4 to S4, whereas the coccygeal plexus is formed by the ventral rami of S4 and S5. So what I wanted to say over here, that these plexus means the branching network, and a nerve plexus is nothing more than a system, or you say the network of connected fibers that link the spinal nerves with the specific areas of the body. And the ventral rami, I said, except T2 to T12, these branch and join with another to form this network. And there are, as I said, the 5 spinal nerve plexuses are there, and these nerves that arise from these plexuses have both sensory as well as the motor functions. Now, these functions include the muscle contraction, or you can say the maintenance of the body coordination, apart from the control and you say the reaction to the sensations, such as you can say the heat, cold, pain, and pressures. So as I said, we have the different nerve plexuses. So coming to the next slide, when we see, as I said, that today we will be discussing about the brachial plexus. So far we discussed about what is the spinal nerve and what is the plexus. Now we will see what is the brachial plexus. So the brachial plexus, as I said, is a network of nerves which are formed by the ventral rami of the lower 4 cervical nerves. Over here in this diagram, you can see over here the lower 4 cervical nerves, that is C5, C6, C7, C8, and the first thoracic nerve, that is the T1. So what I wanted to say, that the brachial plexus is formed by the ventral rami of C5, C6, C7, C8, and T1. Now, when we see over here, this plexus extends from the spinal cord. You can see over here, this is the spinal cord, through the cervicoaxillary canal in the neck. So over here, you can see this is the cervicoaxillary canal. So through this cervicoaxillary canal in the neck, over the first rib, and then it enters into the armpit. So it supplies the afferent and the efferent nerve fibers to the chest. Over here you can see, and then the shoulder, you can see over here, the arm, forearm, and the hand. So these areas, you can say the upper limb and the shoulder girdle will be supplied by, apart from the pectoral region, will be supplied by the branches of the brachial plexus. Now, when we see this formation of the brachial plexus, as I said, this brachial plexus is formed by the different roots, the ventral rami of C5, C6, C7, C8, and T1. Now, these are called the roots of the brachial plexus. Over here, you can see these are the roots of the brachial plexus. Now, when we see these roots emerge downwards and laterally between the scalenus anterior, in the next diagram, I'll show you over here in the coming diagram. So what I said, that it enters through the cervico-axillary canal over here. And if you appreciate over here, this is the clavicle. This is the clavicle over here. This region, if you appreciate over here, this is the supraclavicular part. And this, just behind the clavicle, we will say the retroclavicular part, and inferior to this clavicle, if you see over here, this we will call it as the infraclavicular part. So when we talk about the formation, this brachial plexus is formed by the ventral rami of the lower 4 cervical nerves and the first thoracic nerves, that is T1, and these emerges downwards and goes laterally between the scalenus anterior and the medius muscle and form 3 trunks, that is the upper trunk, the middle trunk, and the lower trunk in the posterior triangle of the neck. Now, what happens that when we talk about the different roots, that is the C5 and C6, the ventral rami of C5 and C6 will form the upper trunk, whereas the ventral rami of C7 will continue as the middle trunk, whereas the ventral rami of C8 and T1 will form the lower trunk. So what I wanted to say over here, that the different roots will form the 3 trunks. What are those 3 trunks? The upper trunk, the middle trunk, and the lower trunk. I said the upper trunk is formed by the ventral rami of C5 and C6. Then I said the middle trunk is formed by the ventral rami of C7, whereas the lower trunk is formed by the ventral rami of C8 and T1. So once again, I said the ventral rami of C5 and C6 joins to form the upper trunk. The C7 will continue as the middle trunk, whereas the C8 and T1 joins to form the lower trunk. Now, depending on the contribution of other spinal nerves, right, there are 2 conditions. One we call it as the prefixed condition, and another we call it as the post-fixed condition. So I said this rami, if you see over here, there was a question. When we see over here, these are the ventral roots, these are the dorsal roots. Though I will, from next time, questions I will take at the end, right? But because I have seen this question I'm taking, I said there are 2 roots, the ventral roots and the dorsal roots are there. These 2 joins and forms the spinal nerves. Now these spinal nerves will further divide into 2, right? And these divisions, right, of this spinal nerves, that may be the mixed spinal nerves, these divisions are the ventral ramus. These are the ventral ramus. And the another division which is going posteriorly of this spinal nerve, that we will call as the dorsal ramus. So I was talking about the different conditions, that is the prefixed condition and the postfixed condition. So I said basically in the formation of the brachial plexus, there is a contribution from C5 to T1. But depending on the contribution of the other spinal nerves, the different conditions have been defined. One is the prefixed condition and another is the postfixed condition. In the prefixed condition, there will be contribution from the C4, right? And the contribution from T1 will be diminished. Whereas when we talk about this postfixed condition, what will happen that there will be contribution from the T2, whereas the contribution from C5 will be diminished. So there are 2 types of conditions. One is the prefixed condition and another is the postfixed condition. In prefixed condition, there will be no effect as such, but because of the in postfixed condition, there may be some changes because of the presence of the rib. It may compress some of the structures, and because of that, you will find some of the clinical conditions. Now, when we see the different components of the brachial plexus, there are the different components of the brachial plexus. As I said, we have the roots, and then these roots forms the trunks. Now, if you can see over here, as I said previously, that the ventral roots of the ventral rami of C5 and C6 will form the upper trunk. Over here, you can see this is the superior or the upper trunk in the diagram. This is the schematic diagram over here. You can see C7 will continue as the middle trunk, right? And C8 and T1 will join and will form the lower trunk. Now, what will happen that these trunks will have two divisions. Each trunk will divide into two. One is the anterior division and another is the posterior division. If you see in this diagram over here, the black color denotes, if you see this black color, it demarcates that is the anterior division over here. Whereas if you see this yellow color, right, it marks the posterior division. So what I said that each trunk will divide into two. One is the anterior division and another is the posterior division. Now, over here, you can see this is the upper trunk, this is the anterior division of the upper trunk, and this is the posterior division of the upper trunk. Similarly, when you see this middle trunk, it also divided into two. That is, the two divisions are, this is the anterior division, the black color, whereas this yellow color, which you can see over here, is the posterior division of the middle trunk. Similarly, when you see this lower trunk, it also divides into two, the posterior division and we have the anterior division. So each trunk divides into two divisions. There are two divisions. Now what will happen that another component of the brachial plexus is our cords. Now we have roots, trunks, and divisions. Now what will happen that the different divisions of this brachial plexus will form three cords. And these cords are the lateral cord, we have the posterior cord, and then we have the medial cord. Now, when you see this lateral cord, the lateral cord is formed by the anterior division of the upper trunk and the anterior division of the middle trunk. So you can see over here, the anterior division of the upper trunk and the anterior division of the middle trunk forms the lateral cord of the brachial plexus. Now, when you see over here, this is the medial cord of the brachial plexus. The anterior division of the lower trunk will form the medial cord of the brachial plexus. Whereas all the posterior divisions, the posterior division of the upper trunk, posterior division of the middle trunk, the posterior division of the lower trunk, these three posterior divisions will form the posterior trunk. So we have posterior cord. So we have three cords, the lateral cord, the medial cord, and the posterior cord. The lateral cord, I repeat, is formed by the anterior division of the upper trunk and the anterior division of the middle trunk. The medial cord is formed by the anterior division of the lower trunk, whereas the posterior cord is formed by the posterior division of upper trunk, middle trunk, and the lower trunk. So we have the roots, we have trunks, we have divisions, we have cords, and these cords will give the various branches. There will be the various branches of the brachial plexus. We will discuss one by one. Now, when we see this trunk, as I mentioned before, right, these trunks, that is the upper trunk, middle trunk, and the lower trunk, in the diagram you can see over here the schematic trunk diagram, the upper trunk, the middle trunk, and the lower trunk, which is formed by the various roots I have already discussed, so I will not repeat this, right? Again, as I said, we will have, each trunk will have two divisions. One is the anterior division and another is the posterior division. So over here in the diagram, I have already described that the upper trunk will have the anterior division and the posterior division. Similarly, we have the middle trunk and we have the lower trunk. So each trunk will have two divisions, that is the the anterior division and the posterior division. So when you approach this towards the clavicle, right, before entering this axilla, in the previous diagram you can see over here, right, when you approach towards the clavicle, before entering into the axilla, each trunk divides into two, that is the anterior and the posterior division, in order to supply the muscles of the flexor compartment and the extensor compartments, either you talk about the arm or the forearm. So from these three trunks, we have 6 divisions, right? So over here, we can see various divisions over here. Now, when I said that these divisions will form the different cords, and different cords are the lateral cord, the medial cord, and the posterior cord. I said the anterior division of the upper and the middle trunk forms the lateral cord, whereas the anterior division of the lower trunk forms the medial cord, whereas the posterior division of all these three trunks will form the posterior cord, right? So therefore, the lateral cord contains the fibers from C5, C6, and C7. Why so? You can see, I said the anterior division of upper trunk and anterior division of the middle trunk. So anterior division of upper trunk will have fibers from C5 and C6, and the anterior division from the middle trunk will have fibers from C7 fibers. So the branches from the lateral cord will have the C5, C6, and C7 fibers. Similarly, when we see the branches from the medial cord, because this medial cord is formed by the anterior division of the lower trunk, and the lower trunk is formed by C8 and T1. So basically, all the branches from the medial cord will have fibers from C8 and T1. Whereas when we talk about this posterior cord, because this posterior cord is formed by the posterior division of the upper trunk, the posterior division of the middle trunk, and posterior division of the upper trunk. So the some of the branches, if you see, will have the fibers C5, C6, C7, C8, and T1, because the posterior cord has contributions from C5, C6, C7, C8, and T1. Now, when we see these cords, there are the different cords you can see over here. This is the lateral cord, the medial cord, and then we have the posterior cord. Now, these three cords enter the axilla and are arranged according to the names. As I said, we have the lateral cord, we have the medial cord, and we have the posterior cord. So when we see this axillary artery, just before discussing to this axillary artery, I would like to just give a brief idea about this axillary artery. So over here, you can see this red color structure is the axillary artery. This axillary artery is the continuation of the subclavian artery. This subclavian artery extends up to the outer border of the first rib, whereas this axillary artery, when you say, it is the continuation of the subclavian artery. This axillary artery, it extends from the outer border of the first rib to the lower border of the teres major. Now, this axillary artery, it is divided into three parts by the presence of the pectoralis minor. So when you see over here, I said this axillary artery, it is divided into three parts. The first part, which extends from outer border of the first rib to the upper margin of the pectoralis minor, whereas the second part of the axillary artery, it extends from the upper margin of this pectoralis minor to the lower margin of this pectoralis minor, whereas the third part of the axillary artery, when you say, it extends from the lower margin of this pectoralis minor to the lower border of teres major. So when we talk about this, the various cords, right, in relation to the second part of the axillary artery, so the lateral cord will be lying lateral to the second part of the axillary artery, whereas the medial cord will be lying medial to this second part of the axillary artery, and the posterior cord will be lying the posterior to the or behind the second part of the axillary artery. So I repeat, I said the three cords enter the axilla and are arranged according to their names around the second and the third part of the axillary artery, as shown in the figure. You can see this is the lateral cord, this is the medial cord of the brachial plexus, and behind this axillary artery, you can appreciate over here, this is the posterior cord of the brachial plexus. When we talk about the relation of the cords with first part of the axillary artery, it is different. What happens in the first part of the axillary artery? The lateral and the posterior cord of this brachial plexus will be lying lateral to the axillary artery, while this medial cord of this brachial plexus will be lying behind this first part of the axillary artery. So this is all about the cords in relation to the different parts of the axillary artery. Now, when we see this relations of this brachial plexus, now in the neck, this brachial plexus lies in the posterior triangle. Over here, you can see This is the posterior triangle. So in the neck, this brachial plexus lies in the posterior triangle, being covered by the skin. When you remove this skin, you will have the platysma, you have the deep fascia, and it is crossed by some of the supraclavicular nerves, which is further divided into the lateral, intermediate, and the medial supraclavicular nerves. I'm not going in detail about the supraclavicular nerves. So what I said, that you will have deep fascia, which is crossed by the supraclavicular nerves, and you will get the inferior belly of the omohyoid, which get its attachment at the suprascapular notch on the upper border of the scapula. Apart from that, you will be getting this external jugular vein and the transverse cervical artery. It emerges between the scalenus anterior and the medius muscle. Over here in this diagram, you can appreciate, this is the green color structure which you can appreciate over here is the scalenus anterior, and towards the posterior aspect, if you can appreciate this green color structure, this is the scalenus medius. So it emerges between this scalenus anterior and the medius, and its upper part lies above the third part of the subclavian artery. So over here, you can see this is the third part of the subclavian artery. I said the subclavian artery extends up to the outer border of the first rib, right? When you see this trunk is formed by the union of the lower trunk. When we talk about the lower trunk, is formed by the union of the 8th cervical and the first thoracic vertebra, which is placed behind the artery, and this plexus next passes behind this clavicle. Over here, you can see the cut part. This clavicle has been removed, and you can see behind this cut part of the clavicle, you can find this brachial plexus over here. So when you see this brachial plexus, it next passes behind this clavicle, the subclavius muscle, which is lying on the inferior surface of the clavicle. On the inferior surface of the clavicle, you have the subclavian groove, right? And in the floor of the subclavian groove, you have the attachment of this subclavius muscle. And then apart from this subclavius muscle, you will be getting this transverse scapular vessels. So all these structures will be related to this, and these will lies on the first digitation of the serratus anterior muscle. Now, apart from this, when we find this serratus anterior muscle, apart from this, you will be getting the subscapularis muscle, right? And then it enters into the axilla over here, you can say, and in the axilla, it is placed lateral to the first part of the axillary artery. I said lateral to the first part of the axillary artery, you will be getting the lateral cord of the brachial plexus and the posterior cord of the brachial plexus. And as I said, the medial cord will be behind this first part of the axillary artery. And when you see this second part of this axillary artery, the different cords will be related according to the name. Now, that is one cord lying medial to it, that is the medial cord will be lying medial to it, lateral cord will be lying lateral to the second part of the axillary artery, and the posterior cord of the brachial plexus will be lying behind or the posterior to the second part of the axillary artery. And then it gives the terminal branches to the upper limb. So this is all about the relations. So in this diagram, you can see over here, these are the different roots. Different roots forms the trunks, the upper, middle, and the lower trunk. These trunks will divide into the different divisions, the anterior and the posterior division, anterior and the posterior division. So there will be 6 divisions. These divisions will form the cords, the lateral, medial, and the posterior cord of the brachial plexus. And then these cords will give the different branches. So this is all about the relations of the brachial plexus. Then we will see the branches from these brachial plexus. Now, when we see this brachial plexus, which are formed from the ventral rami, or we say the roots designated spinal nerves. So we will have the branches from the roots, we will have branches from the trunks, and then we will have branches from the cords of the brachial plexus. Now, when we see these branches from the roots, we will have the different branches from the roots. The very first branch, which you can see over here in this slide, we have the branches from the roots are the dorsal scapular nerve. There will be contribution to the phrenic nerve. when you see this phrenic nerve, there will be contribution from C3, C4, that is from the cervical plexus.
Good evening, all. There has been some technical power surge at Dr. Ravi's point. So wait for 5 minutes. He'll be back. He'll be back joining us back. Thank you so much.
Yeah, so we were discussing about the branches from the roots. So we have the branches from the roots. These are the dorsal scapular nerve. Contribution will be from the roots, that is the C5, that will be contributing to the phrenic nerve. Then apart from that, we have the long thoracic nerve. Right over here in this diagram, you can see there is a contribution to the phrenic nerve from C5. Then we have the dorsal scapular nerve. Over here you can see. Then apart from that, you can see over here the long thoracic nerve, right? This is the long thoracic nerve over here. And there will be the muscular branches to the longus colli and the scalene muscle. There also the fibers will be from C5, C6 and C7. Now, when we see over here, this dorsal scapular nerve, it is also called as nerve to rhomboids because it gives branches to the rhomboids major and the minor. Apart from that, it also gives twigs to the levator scapulae, which you will find on the medial border of the scapula towards the dorsal aspect. So this, if you see over here, this fibers, that is the dorsal scapular nerve, it pierces this scalenus medius and passes beneath this levator scapulae. There it gives a twig to the levator scapulae, and then it accompanies this descending scapular artery and supplies both, that is the rhomboids major as well as rhomboids minor muscle. Then, as I said, there will be contribution to the phrenic nerve from C5. Then coming to the long thoracic nerve over here. When you see this long thoracic nerve, it is also called as nerve of Bell, or otherwise we call it as the nerve to serratus anterior, right? Because it gives innervation to the serratus anterior muscle. It arises from the dorsal aspect with the root values C5, C6 and C7. What happens initially? It comes from C5 and C6. These roots pierce this scalenus medius and passes downwards behind this brachial plexus. Later, what happens? They unite and enter the apex of the axilla behind the first part of the axillary artery. And then what will happen? That there will be contribution from the C7. So C5 and C6 will be joined by C7, and then it supplies this all the digitations of this serratus anterior muscle. So what I wanted to say that this long thoracic nerve or nerve of Bell presenting, I'm on this present slide only. I'll come to the next slide. Don't worry, right? So what I wanted to say that this long thoracic nerve will be supplying the serratus anterior muscle, right? Where these C5, C6 and C7 roots, these joints and forms a trunk, and this nerve will be closely applied to the serratus anterior, and it descends towards the posterior to the, you say, the mid axillary line and supplies this serratus anterior muscle. There are muscular branches, as I said, that will be giving branches to the longus colli and the scalene muscle. Now, when we see the branches from the trunks, there are two branches from the trunks. You can appreciate in this diagram. This is the upper trunk over here, or the superior trunk. From the superior trunk, we have two branches. One is the nerve to subclavius, and another is the suprascapular nerve. So in this diagram, you can appreciate over here, this is the suprascapular nerve, and inferiorly you can appreciate this is the nerve to subclavius. So nerve to subclavius, it arises from the upper trunk of the brachial plexus and carry fibers from C5 and C6, because I said it is a branch from the upper trunk, and upper trunk is found by C5 and C6. Then it descends in front of the brachial plexus and subclavian vessels and supplies the subclavius muscle, which is present on the inferior surface of the, which is attached on the inferior surface of the clavicle on the floor of the subclavian groove. Now, when you see over here this suprascapular nerve, this is a prominent nerve you can appreciate over here. It carries fibers same, that is C5 and C6. Now, these nerve fibers passes above, means what happens that when you see this upper border of this scapula, there on the superior border of the scapula, there is a suprascapular notch, and that notch is converted into a foramen by transverse scapular ligament. Now, what is the beauty? When it is this notch is converted into a foramen by the presence of this transverse scapular ligament, this suprascapular nerve passes through this foramen, and the suprascapular vessels will be passing above this ligament, right? Now, this suprascapular nerve will pass through that foramen. It will supply this supraspinatus muscle. After supplying the supraspinatus muscle, what will happen that it passes, it winds around this spinoglenoid notch, right? And then it descends downwards and it supplies the infraspinatus muscle. So basically this suprascapular nerve supplies this supraspinatus muscle and infraspinatus muscle. These nerve will pass backwards above the clavicle, you can say, and it runs beneath this anterior border of the trapezius, right? And it will supply the supraspinatus and the infraspinatus muscle. Now coming to the branches from the cords of the brachial plexus. Now when we see this branches from the cords of the brachial plexus, I said three cords are there. One is the lateral cord, and another is the medial cord, and the third one is the posterior cord of the brachial plexus. Just to remember the various branches from these cords, we have the mnemonics, right? You might have heard about a scooter brand, we call it as the LML Vespa. So why I'm mentioning this LML Vespa? This LML stands for the branches from the lateral cord of the brachial plexus. So from the lateral cord of the brachial plexus, for L, we have the lateral pectoral nerve, you can see over here. Then from M, we have this musculocutaneous nerve. And then the third one, that is the lateral root to the median nerve. So from the lateral cord, we have three branches. I repeat, one is the lateral pectoral nerve, another is the musculocutaneous nerve, the third one is the lateral root to the median nerve. Similarly, when we see the branches from the medial cord of the brachial plexus over here, we have given the mnemonic M for U, means 4M and 1U. 4M, 1M, that is the medial pectoral nerve. Over here, we have the lateral pectoral nerve from the lateral cord. Similarly, from the medial cord of the brachial plexus, we have the medial pectoral nerve. Similarly, from the lateral cord, we have the lateral root to the median nerve. From the medial cord, we will have the medial root to the median nerve, right? Then we have the medial cutaneous nerve of arm, and then we have the medial cutaneous nerve of the forearm. So there are 4M, and one is the ulnar nerve. So these are the branches from the medial cord of the brachial plexus. What are those? I repeat, we have the medial pectoral nerve, we have medial cutaneous nerve of the arm, we have the medial cutaneous nerve of the forearm, then we have the medial root of the median nerve. Apart from these 4M, we have the fifth one, that is the ulnar nerve. So from the lateral cord, we have three branches, right? We have from the medial cord, we have 5 branches. Similarly, from the posterior cord of the brachial plexus, we have 5 branches. Now, from branches from the posterior cord, we have given mnemonic, we call it as the ultra, or we have given another mnemonic, we can say ulnar. Now, you can see ultra, U, L, T, R, and then we have the axillary nerve, that is the ultra. So, U stands for the upper subscapular nerve, L stands for the lower subscapular nerve, T stands for the thoracodorsal nerve, R stands for the axillary nerve, and R stands for the radial nerve, and A stands for the axillary nerve. So these are the 5 branches from the posterior cord of the brachial plexus. When we write this mnemonic ulnar, means U stands for the upper subscapular, L stands for the lower subscapular, N stands for the nerve to latissimus dorsi. So either you say thoracodorsal nerve or you say nerve to latissimus dorsi, both are same. Then A stands for the axillary nerve and R stands for the radial nerve. So these are the various branches from the posterior cord of the brachial plexus. I hope I'm clear. Once again, from the lateral cord, 3 branches: lateral pectoral nerve, musculocutaneous nerve, and lateral root to the median nerve. From medial cord, 5 branches. We have the medial pectoral nerve, medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm. Then we have the medial root to the median nerve, and then we have the ulnar nerve. From the posterior cord, again, we have the 5 branches, and these are upper subscapular, lower subscapular, nerve to latissimus dorsi, axillary nerve, and then we have the radial nerve. So these are the various branches from the various cords of the brachial plexus. Now we will see the branches from the lateral cord of the brachial plexus. As I said, we have 3 branches: lateral pectoral, musculocutaneous, and then lateral root to the median nerve. when we talk about this lateral pectoral nerve, as just remember that all the branches from the lateral cord of the brachial plexus will have root value C5, C6, and C7. Remember, I said all the branches here, I've missed writing this C5. So all the branches from the lateral cord will have root value C5, C6, and C7 because it comes from the this upper trunk and the anterior division of the middle trunk, right? Now, if you see over here, this lateral cord, the lateral pectoral nerve will carry fibers C5, C6, and C7, and it will supply the pectoralis major and the pectoralis minor muscles by piercing this clavipectoral fascia. And it can be identified by a loop of communication formed with the medial pectoral nerve in front of the first part of the axillary artery. Coming to the musculocutaneous nerve, when we see this musculocutaneous nerve, initially it lies lateral to the third part of the axillary artery. What happens? It pierces this coracobrachialis. After piercing this coracobrachialis, it gives innervation to the coracobrachialis. Remember, after piercing this coracobrachialis, it supplies this coracobrachialis muscle, and then in the arm, it supplies the both heads of the biceps brachii, that is the long and the short head of the biceps brachii, and the medial part of the brachialis. Because brachialis has dual nerve supply, the brachialis will also get its innervation from the radial nerve, that is the proprioceptive branch of the radial nerve. So what I wanted to say that this lateral pectoral nerve gives branches to all the muscles of the anterior compartment of the arm. Means what I said that this musculocutaneous nerve will supply all the muscles of the anterior compartment of the arm. These are the coracobrachialis, the biceps brachii, and then the third one is the brachialis, right? Now what will happen that after supplying this medial part of the brachialis and the two heads of the biceps brachii, what will happen that it will pierce the deep fascia lateral to the biceps tendon, and it will continue as the lateral cutaneous nerve of forearm to supply the anterolateral region of the forearm till you can say the base of the thinner eminence. So this is all about the this musculocutaneous nerve. Coming to the branches from the over here in this diagram, you can appreciate this is the lateral pectoral nerve, right? Then you have this musculocutaneous nerve, and this is the lateral root to the median nerve. This lateral root and the medial root to the median nerve both will join and will form the median nerve. In the next diagram, next slide, we'll see the branches from the medial cord of the this brachial plexus. Now, you can see in this diagram over here, we have from the lateral cord, this is the lateral root to the median nerve, and from the medial cord, we have the median root to the median nerve. These two roots joins and form the median nerve. So over here, you can see this median nerve. This median nerve is formed in front of the third part of the axillary artery by the lateral root and the medial root of the medial cord. The lateral root will carry the fibers C5, C6, C7, whereas the medial root of the medial cord will carry the fibers C8 and T1. What happens? Then the trunk of the median nerve descends lateral to the axillary artery. Remember, in the arm, this median nerve doesn't supply any muscle. It doesn't give any branch to any muscle in the arm. Now, coming to this medial pectoral nerve, this is the first branch of this medial cord, you can say, which arises behind the first part of the axillary artery, and it supplies the pectoralis minor, and it also supplies the pectoralis major muscle. Then we can see over here this medial cutaneous nerve of the forearm. This lies between the axillary artery and the vein. Over here you can see this is the axillary artery. Medial to this we will have the axillary vein over here. So this is located, this lies between the axillary artery and the vein, and it supplies the skin of the lower part of the arm and the anterior medial surface of the forearm up to the wrist, you can say over here. Then the another branch from the medial cord of the brachial plexus will have the medial cutaneous nerve of the arm. This is the smallest branch of the medial cord, and it lies medial to the axillary vein. It receives communication. If you see over here, what will happen? That it will receive communication from the intercostobrachial nerve, and after piercing the deep fascia at the middle, of the arm. It supplies the scheme over the medial side of the distal third of arm. And then the last branch from this medial cord of the brachial plexus we have is the ulnar nerve. You can appreciate over here in this diagram, this is the ulnar nerve, which carries the fibers C8 and T1, but there will be some terminal fibers or the additional fibers of the C7, right, which joins at the end, and because of that, the root value of the ulnar nerve becomes C7, C8, and T1, and it supplies the flexor carpi ulnaris muscle in the forearm, right? Even the ulnar nerve doesn't give branch to any muscles in the arm. It supplies the muscles of the forearm. There are one is the flexor carpi ulnaris muscle, and another we have the flexor digitorum profundus. So the medial half of the flexor digitorum profundus will get its innervation by the ulnar nerve, and the most of the muscles of the hand will be getting innervation from the ulnar nerve. This ulnar nerve is also known as musician's nerve. Similarly, this median nerve is also known as laborer's nerve because it is responsible for the coarse work. Similarly, this ulnar nerve is responsible for the fine work. So that's why we call it as the musician's nerve as well. Now we will see the branches from the posterior cord of the brachial plexus. We have the upper subscapular nerve, which carries over here. You can see this is the upper subscapular. There will be a small fiber twig which will be supplying this upper subscapular, will be supplying the subscapularis muscle, whereas the lower subscapular, it will also carry the C5 and C6 fibers, and it will not only supply the lower part of the subscapularis, but this lower subscapular nerve supplies the teres major as well. Then coming to the thoracodorsal nerve, which is quite long, this thoracodorsal nerve, or you say the nerve to latissimus dorsi, right? It, which is a branch from the posterior cord of the brachial plexus. It is present between the upper and the lower subscapular nerve, and it carries the fibers of C6, C7, C8. So what I wanted to say, otherwise, as I said, that all the branches of the lateral cord of the brachial plexus will have root values C5, C6, and C7. Similarly, all the branches of the medial cord of the brachial plexus will have root value C8 and T1, except ulnar nerve, where you have the additional fibers of the C7. So the ulnar nerve will have root value C7, C8, and T1. Similarly, when we say about the branches of the posterior cord of the brachial plexus, right, the most of the branches of the posterior cord of the brachial plexus will have root value C5 and C6, except this thoracodorsal nerve and the radial nerve. The thoracodorsal nerve will have root value C6, C7, C8, whereas the radial nerve, because it has contribution from all, so the root value of the radial nerve will be C5, C6, C7, C8, and T1. Hope I am clear. I said all the branches from the lateral cord of the brachial plexus will have root value C5, C6, and C7. Then I said all the branches from the medial cord of the brachial plexus will have root value C8 and T1, except ulnar nerve, where the additional fibers or the terminal fibers of C7 are there. So the root value of ulnar nerve will become C7, C8, and T1. Similarly, I said all the branches from the posterior cord of the brachial plexus will have root value C5 and C6, except thoracodorsal nerve and the radial nerve. The thoracodorsal nerve will have root value C6, C7, and C8, whereas the radial nerve will have root value from C5 to T1. So this, I said, thoracodorsal nerve will be supplying this latissimus dorsi muscle. Then coming to the very stout branch, or you say the circumflex nerve, or we say the axillary nerve, right? This carries the fibers, as I said, C5 and C6, and it will be lying behind the third part of the axillary artery and lateral to the radial nerve. If you see over here, this is the radial nerve. It will be lying lateral to the radial nerve. This is the axillary nerve you can appreciate over here, right? Now what happens? It enters the quadrangular space, right? And then it supplies the two muscles. One is the deltoid and another is the teres minor. So along with this posterior circumflex artery, it enters into the quadrangular space, and then it supplies the deltoid and the teres minor and ends as the upper lateral cutaneous nerve. Now coming to the largest branch, you can say, or the thickest branch of this posterior cord of the brachial plexus, that is the radial nerve. So radial nerve is otherwise continuation of the posterior cord, and as I said, it is the largest branch of the brachial plexus, and it carries fibers from C5 to T1. So it lifts the axilla through the lower triangular space to lie on the radial groove along with the profunda brachii artery, and it supplies all the muscles of the extensor compartment of the arm as well as the extensor compartment of the forearm. Right? Now coming to the, if we see in the next, we'll just revise the different muscles, and these muscles are supplied by which nerve. So one by one we will see over here. So this is the serratus anterior muscle. This is virtual, so I cannot interact with the students. I can say this is the serratus anterior, and this is supplied by nerve to serratus anterior. Otherwise, it is called as nerve of Bell, or it is called as long thoracic nerve. The root value is C5, C6, and C7. Then, if you see over here, this is the pectoralis major, which is supplied by lateral and the medial pectoral nerve. The root value is root value of the lateral pectoral nerve is C5, C6, and C7, whereas the root value of the medial pectoral nerve will be C8 and T1. Then coming to the next muscle, you can appreciate over here. This is the latissimus dorsi. It is supplied by the nerve to latissimus dorsi, or we say thoracodorsal nerve, right, which is a branch from the posterior cord of the brachial plexus, and the root value will be C6, C7, C8. Coming to the next muscle, if you appreciate over here, this is the supraspinatus muscle. This supraspinatus muscle, it is supplied by suprascapular nerve, and the root value of the suprascapular nerve will be C5 and C6. Similarly, when you see this subscapularis muscle, the subscapularis muscle, it is supplied by upper and the lower subscapular muscle, upper and lower subscapular nerve, which are branches from the posterior cord of the brachial plexus, and the root value will be C5 and C6. Then coming to the, this is the deltoid muscle. Now deltoid, as I just now said, it is supplied by the axillary nerve. The root value will be C5 and C6. Then if you see over here, these are the rhomboidus muscle. I said either you talk about the levator scapulae, the rhomboidus minor, or the rhomboidus major. All these are supplied by the dorsal scapular nerve, and the root value will be the you say the C5. Then you can see over here the triceps. I said all the muscles of the extensor compartment of the arm and the forearm are supplied by the radial nerve or the branches of the radial nerve. You can see over here the biceps brachii. This biceps brachii, as I said, it is supplied by the musculocutaneous nerve, right? So already I discussed the muscles. If you see the anterior compartment of the forearm, the most of the muscles of the anterior compartment of the forearm is supplied by the branch of the median nerve, the anterior interosseous nerve, except if you see the flexor carpi ulnaris and the medial part of the flexor digitorum profundus, which is supplied by the ulnar nerve. The extensor muscles, I have already said, it is supplied by the radial nerve. Now we will be discussing about the applied aspect of this brachial plexus. Clinically, it is very important, right? So when you see this brachial plexus, the injury of the brachial plexus is not very uncommon, to be very frank. And there are various reasons, right, that includes the road traffic accident. You can say the penetrating injuries can be there. There can be the surgical complications. There may be the due to the birth injuries, or even due to the domestic violence. And you can say the different accident, as I said, the road traffic accident. So when we talk about this tractional injuries, this closed tractional injuries, this leads to the traumatic brachial, you say, the plexopathies. And there can be the supraclavicular injuries, or there can be infraclavicular injuries. There may be the root avulsion, and root avulsion will be more serious. In case of the supraclavicular injuries, if you see, that may be because of the forced separation of head and shoulder, you can see over here, right? There may be, as I said, infraclavicular injuries, and this may be because of the forced separation of the arm from the torso, or you say the hyperabduction. I'll show you in the diagram, in the coming diagram. So these ventral roots are more prone to injury. Why it is so? Because these are the calibers will be lesser calibers, and then apart from that, even the dural sac is quite thin, or you can say the thinner dural sac. Now coming to this obstetric, this brachial plexopathies, that is the injuries related to the obstetric causes. There may be obs palsy, right? There may be, you say, the C5 to T1 with some finger flexion sparing. There may be flail arm and this Horner's syndrome, you can say. And apart from that, there may be clunkage palsy. So all these may be because of the obstetric region, the injury to the brachial plexus. We'll be discussing one by one. So when you see this obs palsy, I said this upper trunk is formed by the ventral ramus of C5 and C6, right? That is the upper trunk. Now upper trunk divides into two, that is the anterior division and the posterior division. So the meeting point of the 6 nerves is called as the obs point. Now if you see, very commonly these questions are asked, what is obs point? So enumerate the 6 nerves, right, which meets and forms this called as the obs point. So what are those 6? One is the ventral ramus of C5, another is the ventral ramus of C6. Then you have two branches from the upper trunk. These are the suprascapular nerve, and then another is the nerve to subscapularis. Sorry, over here, this is the wrong. It is nerve to subclavius. This is the typing error. You remember, I said from the upper trunk, there are 2 branches are there. One is the suprascapular nerve and another is the nerve to subclavius. So these are the 4 nerves, and then we have the anterior division of the upper trunk and the anterior division of the posterior division of the upper trunk. So these are the 6 nerves which meets, and the meeting point of these 6 nerves are called as obs point. And if there is an injury to this obs point, the clinical condition we call it as the obs palsy. I once again enumerate these 6 nerves: the ventral ramus of C5, the ventral ramus of C6, then suprascapular nerve. The 4th one is nerve to subclavius. The 5th one is the anterior division of the upper trunk, and the 6th one is the posterior division of the upper trunk. Now, when we see this neurologically, I said this obs point is a site at the upper trunk of the brachial plexus, which is located 2 to 3 centimeter above the clavicle, which is formed by, as I said, the union of the C5 and C6 roots, you can see over here, which converge to form the upper trunk and lateral divide, the anterior and the posterior divisions. So whenever we have this suprascapular nerve and the subclavius, whenever there is an injury to this point, that clinical condition we call it as the obs palsy. Now, what are the causes behind this obs palsy? We'll see over here in the next slide. Injury to the upper trunk, I said at the obs point, right? I said it leads to the obs palsy. Now, this may be because of the traction on the arm at the birth. You can see over here when we pull, right? There may be because of the traction on arm at the birth or due to accident. You can see over here, right? There may be the nerve root avulsion from the cord that is involving the C5 and C6, and affected nerves in obs palsy are usually the axillary nerve, whoever the root value will be the C5, C6, like the axillary nerve, you say the musculocutaneous nerve, the suprascapular nerve. All these will cause the paralysis to the deltoid, the biceps, you say the brachialis, the brachioradialis, and the supinator muscles. So all these are, you can see in this diagram, are the various causes. And when you see the presentation of this obs palsy, what will happen? That abduction, the lateral rotation of arm, and flexion and supination of the forearm will be lost. So usually the presentation of the obs palsy will be the upper limb hanging by the side of the trunk, and you can see over here how the waiter's stiff hand or the policeman's stiff hand, we say, or the porter's stiff hand usually is defined. We call the presentation of this obs palsy, right? So the loss will be the abduction, I repeat, the lateral rotation of the arm and flexion and supination of the forearm will be lost. So the arms will be hanging by the side and it will be rotated medially. Forearm will be extended, you can see over here, and it will be pronated with the flexed fingers and wrist. So deformity is, as I said, it is also known as policeman's tip hand. Okay, you must have seen how the police people, they they gets the tip, so that's why we call it as the policeman's tip or the porter's tip hand. So also apart from that there will be sensory loss over the arm. So Erb's palsy, when we say, it occurs approximately 1 in every 400 births, and it this is all about the presentation of the Erb's palsy. You say this is more than enough. Then coming to the clump-cage palsy, or this clump-cage palsy or the paralysis, it occurs due to the injury to the lower trunk of the brachial plexus. So injury to the lower trunk of the brachial plexus will be caused or due to the hyperabduction. You can see in this image, either in this image, or you can see it is due to the hyperabduction of the arm, that is the extended arm in a breech delivery, you can see, or a person falling on the outstretched hand may lead to the clump-cage paralysis. And in this, the C8 and T1 fibers will be injured. Sometimes there will be involvement of C7 also. So the intrinsic muscles of the hand and the flexors of wrist and fingers are affected. So it can result in claw hand, or you say the Horner's syndrome. We will be seeing in the coming slide. So you can see over here, this is the claw hand, right? There may be partial claw hand, there may be complete claw hand. So when there is an involvement of there is an injury to the ulnar nerve as well as median nerve, there will be complete claw hand. When either of the nerve is injured, it is the partial claw hand. So partial claw hand, or you say the claw hand deformity, there is a paralysis of flexors and the fingers involving C6, C7, C8 fibers and all intrinsic muscles of the hand that carries the nerve fibers carrying the C8 and T1 fibers, and anesthesia along the ulnar border of the forearm, and the hand will be there. Then coming to the Horner's syndrome, if you see over here, there may be injury to the sympathetic fibers to head and neck that will lead to the Horner's syndrome. This is basically injury to the sympathetic fibers to head and neck. And when you see this Horner's syndrome, there will be, in this condition, the eyelid of the patients, you see there will be the left eye droops, or the eye droops will be there. The condition, we say the ptosis, in which a constricted pupil, you say the ptosis, miosis, anhidrosis, these will be the presentations in case of the Horner syndrome. And it is caused by this anhidrosis, if you say, it is caused due to the damage of the cervical sympathetic chain. So this is because they leave the spinal cord via T1. So this is all about the Horner syndrome. Then coming to the winging of the scapula. You know, the serratus anterior, when you see this muscle over here, the serratus anterior, it is supplied by the long thoracic nerve, or we say the nerve of Bell, or you say the nerve to serratus anterior. So when there is an injury to this long thoracic nerve or nerve to serratus anterior or the nerve of Bell, you say, this condition will be there, that is called as the winging of the scapula. This results from the blows on the posterior triangle of the neck. Whenever there is an injury to this nerve, it will lead to the winging of the scapula. And because this nerve supply the serratus anterior muscle, so there will be paralysis of the serratus anterior muscle, which stabilizes this scapula. And when it gets paralyzed, what will happen, that the medial border of the scapula will gets prominent, right? So there will be inability to protect and rotate the scapula during the abduction of the arm above the head. Apart from that, what will happen, that the medial border, you can see in this diagram, the medial border and inferior angle of the scapula will be elevated during the pushing or the punching movements. So this is all about the winging of the scapula. So in nutshell, just I wanted to say that winging of the scapula is caused due to injury to the long thoracic nerve. If there is injury to this long thoracic nerve, it will lead to the paralysis of the serratus anterior muscle, and that will lead to the winging of the scapula. Now, if you see over here, there may be the supraclavicular brachial plexopathies. Otherwise, we'll see this burner syndrome or stinger syndrome. You can see the persons falling on each other. So whenever there will be the forceful separation of head and shoulder, it may lead to this burner or the stinger syndrome, right? Similarly, when we see over here, this condition, we say the Ruxy palsy or the cadet palsy or the backpack palsy. In this, what will happen that the classical presentation will be there. There will be pain and weakness associated with the wearing a backpack. You can see over here in this diagram, or in this diagram you can appreciate. So there will be sensory involvement, and most are due to the demyelinating conduction block. We call it as the neuroplexia of the brachial plexus. So this condition, we call it as the Ruxy or the cadet palsy or the back palsy. When they carry this backpack for the longer duration, right, it may lead to this condition. Then infraclavicular brachial plexopathies, the crutch palsy, when the persons wears these crutches in the axilla, right, what will happen that this radial nerve gets compressed, and that will lead to the clinical condition. We call it as the crutch palsy. It may be temporary, right? When the compression gets relieved, it may come to normal condition. Then we have this mid-shaft clavicular fracture. So in that, what will happen? There may be injury to the medial cord. So in case of the, there usually students get confused that in crutch palsy, there is an injury to the axillary nerve. No, it is not so. There is an injury to the radial nerve in the axilla, and that clinical condition we call it as the crutch palsy. Then coming to the very important thoracic outlet syndrome. What will happen when there is a extra rib, the presence of the extra rib, we call it as the cervical rib, right? This clinical condition may occur. We say thoracic outlet syndrome. The clinicians, the same condition, sometimes they say the thoracic inlet syndrome, right? So what happens in this thoracic outlet syndrome? There will be compression of the subclavian artery along the lower trunk of the brachial plexus, the lower trunk. So it means there will be involvement of the C8 and T1 fibers. So in case of the thoracic outlet syndrome, there will be the compression of the subclavian artery along with the lower trunk of the brachial plexus in the area of the clavicle because of the presence of this cervical rib, which is extra rib and which is not usually present, right? So because of this, what will happen? There may be pain in the neck and the shoulders and numbness in the last 3 fingers it may lead. And apart from that, if you see over here towards the inner forearm, there will be pain, and the radial pulse may be easily obliterated by the movements of the arm, particularly with the arm extended and abducted at the shoulder. So sometimes what will happen that the brachial plexus is fibers compromised by a translucent band extending from you say the rudimentary cervical rib to the first rib, and because of that, what will happen that C8 and T1 fibers are mostly affected. So this is all about the thoracic outlet syndrome. Just to revise, I said because of the presence of the cervical rib, there will be compression of the subclavian vessels, right, and the lower trunk of the brachial plexus. That will lead to the thoracic outlet syndrome. Over here in this diagram, you can see over here, right? Okay. Now, very important clinically, that is the brachial plexus block. Now, brachial plexus block is a regional anesthesia technique that is sometimes evolved as an alternative, or you say as an adjunct to the general anesthesia for surgery of the upper extremity. So this technique involves the injection of the local anesthetic agents in the close proximity of the brachial plexus or to the brachial plexus, you say. What happens that in that there will be the temporary blocking of the sensation, and there will be temporary blocking of the ability to move this upper extremity. The patient can remain awake during this surgical process. Over here, you can see there are the different, over here, you can see this is the posterior border of the sternocleidomastoid muscle over here, right? This is the sternocleidomastoid muscle. There are two heads. One is the sternal head, another is the clavicle head. Over here, this is the posterior border of the sternocleidomastoid muscle. Then you can appreciate the external jugular vein over here in this diagram. That is the red color, right? And you can see over here, this is the interscalene groove. Over here, you can see this is the level of the cricoid. This is the level of the cricoid. So over here, we give, that is the interscalene approach. So when we give injection in the interscalene groove, that is the interscalene approach, there can be supraclavicular approach also. Over here, you can appreciate this is the clavicle, right? So this is the red color structure you can appreciate over here is the subclavian artery, right? And over here, you can appreciate this is the jugular notch or sternal notch, right? So when the this injection is given over here, that is in the supraclavicular region, we call it the supraclavicular approach. Then there may be another approach, that is the vertical infraclavicular block. So over here, you can see this is the clavicle, right? Over here, you have this sternal notch, right? And this is the midpoint of the clavicle. So the vertical ventral apophysis of this acromion process, if you see over here, will be, because if you see this is the lateral end of the clavicle, right? Over here, you will be getting this acromion process of this scapula, right? So when you see over here, needle will be entered at the entry at the right angles of the table over here in this, you can say. So this is the infraclavicular block in this area if we give. Then we have the axillary approach where we give along with the axillary artery, you can see over here in the which is marked as A over here, right? So needle entry at the lateral border of the pectoralis major, that is the axillary approach. Over here in this diagram, you can very well appreciate this is the over here, you can see in this diagram, there are the different approaches. This is the axillary approach. Over here, we have the infraclavicular approach. Then we have the supraclavicular approach. And then we have the interscalene approach. So there are the different approaches through which the brachial plexus is can be blocked, right? So there will be the temporary blocking of the sensation and the ability to move the brachial also the upper extremity, and the patient can remain awake during the surgical procedure or the, you say, the procedure, or they can be sedated, or even they can be fully anesthetized if the condition required, or if it is required, if necessary. So there may be different approaches for the brachial plexus. So this is all about the brachial plexus. Now in this diagram, I would like to summarize this brachial plexus. Over here, you can see the different routes by which this brachial plexus is formed. The brachial plexus is formed by the ventral rami of C5, C6, C7, C8, and T1. There may be the prefixed condition. In the prefixed condition, there will be involvement of C4, right? And in the postfixed condition, there will be involvement of T2. Then we have the different trunks. The trunks will be formed by the ventral rami of C5, upper trunk, ventral rami of C5 and C6, the middle trunk by the C7, and the lower trunk by the ventral rami of C8 and T1. So these are the three trunks over here you can appreciate: upper trunk, middle trunk, and then we have the lower trunk. Now you can appreciate over here, this upper trunk will divide into two: anterior division and the posterior division, right? So over here, similarly, the middle trunk will divide into anterior division and the posterior division, and the lower trunk will divide into the anterior division. So over here in this diagram, you can appreciate all the three anterior divisions. Then we have the posterior division from the upper trunk, posterior division from the middle trunk, and posterior division from the lower trunk, right? Now we'll see the different cords, how the different cords will be formed. So lateral cord is formed by the anterior division of the upper trunk and the anterior division of the middle trunk. So you can see over here the lateral cord. Similarly, when we see this posterior cord, it is formed by the posterior division of the upper trunk, posterior division of the middle trunk, and posterior division of the lower trunk. You can see this posterior cord, which will continue as the radial nerve. Then we have the medial cord, which is continuing as the anterior division of the lower trunk. Now, from the roots, we have the different branches, that is the dorsal scapular nerve and the long thoracic nerve, nerve of Bell, or you say the nerve to serratus anterior, will have contribution from C5, C6, and C7. Dorsal scapular nerve will have root value C5 and only C5, right? Then branches from the trunk, we can see the suprascapular nerve, and then we have nerve to subclavius, right? So we have nerve to subclavius. These are the branches from the trunk. Then there are no branches from the divisions. We have the branches from the lateral cord, that is the lateral pectoral nerve, LML, you remember, lateral pectoral nerve. We have the musculocutaneous nerve and lateral root to the median nerve. Then we will see the branches from the medial cord. We have the medial pectoral nerve. Then we have the medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm. Then we have the medial root to the median nerve. And finally, the fifth branch, that is the ulnar nerve. So these are the 5 branches from the medial cord of the brachial plexus. Then we have the branches from the posterior cord of the brachial plexus, that is the upper subscapular, you can see. Then we have nerve to latissimus dorsi. Then we have the lower subscapular. We have the axillary nerve and the radial nerve. So these are the different branches, 5 branches from the posterior cord of the brachial plexus, right? So we have seen the branches from the medial cord already, the median nerve and the ulnar nerve. So roots, we have trunks, we have divisions, we have cords, and the branches from the different cords of the brachial plexus you can appreciate over here. So this is all about the brachial plexus. I tried to finish in one lecture, right? Usually we take 2 lectures for the brachial plexus, right? So thank you so much for listening to me. I hope I was able to make you understand about the brachial plexus. It is difficult because when you are entering into the medical science for the you are very new to this, the terminologies are new, everything is very new to you, but I have tried to make you understand. Questions will be most welcome. Apart from that, I would like to suggest you that make habit of reading the standard textbook. Always try to read the standard textbook. That will always help you. Why I am asking you or requesting you to read the standard textbook, because all the questions in the you say the NEET examination are from the standard textbook. Even if you appear for the USMLE or the PLAB, you will be asked the questions from the standard textbook. Because when we prepare the questions for the different NEET examinations or for the USMLE or PLAB, we give reference from the standard textbook only, right? So that is all about the brachial plexus. Thank you so much once again.
Thank you so much, Dr. Ravi. Thank you so much for elaborated talks. And there are a lot of feedbacks we have received, and just to our audience. So before we come to the general discussion, there are a few questions that which has come up in our Q&A section. So I just this question on their behalf.
Stop the share. Can I stop the share?
Yes, sir, you can stop the share. No.
Somebody asked, sir, can you repeat the root values again? Okay.
Yes,
so I said better that when you talk about the root values, once again, I'll repeat. This brachial plexus is formed by the ventral rami of C5, C6, C7, C8, and T1, right? So basically, whatever the nerves will be there, the root value will be coming from this. So when you talk about the branches from the roots, there are dorsal scapular nerve. I said the dorsal scapular nerve will have root value C5. Then the branches from the roots, I said long thoracic nerve, the root value will be C5, C6, and C7, right? Then the phrenic nerve will have root value C3, C4, C5, but from the brachial plexus, the contribution will be from the C5. Then I said we have the muscular branches to the scalene or the longus colli. There the root value will be C5 and C6. Then coming to the branches from the trunks. The branches from the trunks, I said we have nerve to subclavius and we have suprascapular nerve. The nerve to subclavius will have root value C5 and C6 because it is a branch from the upper trunk. Upper trunk is formed by C5 and C6, right? So the root value to nerve to subclavius and suprascapular nerve will be C5 and C6. Similarly, the another branch from this upper trunk is the suprascapular nerve. Similarly, because it is branch from the upper trunk, the root value will be C5 and C6. Then coming to the branches from the lateral cord of the brachial plexus. The lateral cord, all the branches from the lateral cord of the brachial plexus will be will have the root value. What I said, C5, C6, and C7. Whether it is lateral pectoral nerve, whether it is musculocutaneous nerve, or we have the lateral root to the median nerve. Then I said branches from the medial cord of the brachial plexus. There are 5 branches from the medial cord of the brachial plexus. All the branches from the medial cord of the brachial plexus will have root value C8 and T1, right? Except ulnar nerve, I said ulnar nerve will have root value C7, C8, and T1 because the terminal fibers C7 joins it, right? So that's why the root value of the ulnar nerve becomes C7, C8, and T1. Then coming to the branches from the posterior cord of the brachial plexus, we have 5 branches from the posterior cord of the brachial plexus. One is the upper subscapular, we have lower subscapular and axillary nerve. The upper subscapular, lower subscapular, and axillary nerve will have root value C5 and C6, right? When you talk about the other branches from the posterior cord of the brachial plexus, which doesn't have the root value C5 and C6, are thoracodorsal nerve, which has root value C6, C7, and C8, whereas the radial nerve, because it gets contribution from all the fibers, the root value will be from C5 to T1, that is C5, C6, C7, C8, and T1, right? Okay. So there is a question again over here that how can I attend more webinars like this? Your already email is with Wolters Kluwer. So whenever they will organize the webinar, right, the link will be sent to you. Then, sir, please repeat again ulnar root values. Okay, I said, beta, just now I said that ulnar nerve is a branch from the posterior cord of the brachial plexus. Medial cord of the brachial plexus. So usually it should have the root value C8 and T1 only. But I said because the terminal fibers, the C7 joins this C8 and T1, that's why the root value of the ulnar nerve becomes C7, C8, and T1. Can you repeat? The 6 nerves meet in the ops point. Yes, I said the ventral rami of C5 and ventral rami of C6. These are the 2. Then the 2 branches from the upper trunk, that is the nerve to subclavius, right, and suprascapular nerve. And there are 2 divisions of the upper trunk, that is the anterior division and the posterior division, right? So these are the 6 nerves, right, which meets at the ops point. And if there is an injury to the ops point, there will be ops paralysis. Okay, then what is the reason for the Horner's syndrome, right? I said that whenever there is a, what happens that C8, T1 fibers are there, sympathetic fibers are there, right? So what will happen that whenever there is contribution, this T1 fibers, when the sympathetic chain leaves this spinal cord via T1 fibers, and when there is a damage to this cervical sympathetic chain, it leads to the Horner syndrome. So usually due to the injury to the sympathetic fibers to head and neck, it leads to the Horner syndrome. I said in the Horner syndrome, there will be different presentation, that is ptosis, meiosis, and anhidrosis, right? What is the standard text, a standardized book for the brachial plexus? I will always recommend a standard textbook like you can say this clinically oriented anatomy, Snell's clinical anatomy, you have the Gray's anatomy, all these books you can refer, right? Sir, please repeat the pain areas in the thoracic outlet syndrome. I said when you see over here, this is the, there will be the pain in the neck areas over here, then towards the medial aspect of the forearm over here, and towards this side. So these areas that you will be able to have the pain. Sir, please repeat the pain areas. Okay. So can you repeat the blood supply? What blood supply? The axillary artery branches. I said if you, what is the blood supply, beta? Which area of blood supply you want? So I think regarding axillary artery only I discussed. So I said this axillary artery, when you see, it extends from the outer border of the first rib to the lower border of teres major. This axillary artery, it is divided into three parts by the presence of the pectoralis minor, right? So from the outer border of the first rib to the upper border of the pectoralis minor, we have the first part of the axillary artery, and from the first part of the axillary artery, we have superior thoracic artery or the supreme thoracic artery. From the second part of the axillary artery, we have two branches which extends from the upper margin of the pectoralis minor to the lower border of the pectoralis minor. And from the second part of the axillary artery, we have two branches, that is the thoracoacromial artery and the lateral thoracic artery. Then when we talk about the third part of the axillary artery, it extends from the lower margin of the pectoralis minor to the lower border of the teres major. And from the third part of the axillary artery, we have three branches. These are the subscapular artery, which is a very small stem, and this subscapular artery will divide into two, that is the thoracodorsal artery, which will be traversing down along this thoracodorsal nerve, and one branch will go towards the posterior aspect, towards the scapula between the two slips of the teres minor, right? Then the other two branches from the third part of the axillary artery are, what are those? One is the anterior circumflex humeral artery, and then we have the posterior circumflex humeral artery, right? Why does the posterior and the anterior branch consist only on the ventral rami of C5? I didn't understand. Why does the posterior and the anterior branch consist only on ventral rami of C5? I didn't understand what you are asking. The ventral rami of C5, can you, how the roots of the spinal nerves are different from roots of the brachial plexus? There are the roots of the spinal nerve only that forms the brachial plexus, right? So there are the different roots of the spinal nerve which forms the different plexuses. I said we have the cervical plexus, we have the brachial plexus, we have the lumbar plexus, we have the sacral plexus, we have the coccygeal plexus, right? So this is it is 6:30. If you have further more questions, you have my email ID drksravi.jipmer@gmail.com, right? So I would appreciate any confusion. If you have, you are most welcome to ask, right? I can answer on the mail, I can answer on the WhatsApp also.
Thank you, Dr. Ravi. Thank you so much for your time today, sir. Also, by keeping in mind the time that we have today, I also would like to tell all the audience that this is a very large topic, and it is also, I think we can spend another good 2 hours to explain the topic.
Sir. Actually, we take this lecture in 2 sessions, right?
Exactly.
Can I explain? Exactly, I am not able to send the message.
Sir, that I will look into it. But before that, I want to tell all my audiences that we are planning such 15 webinars on top topics in anatomy. And Dr. Ravi will be taking 5 of the topics from those 15 webinars. And the
Thank you, sir.
10 webinars will be taken by Dr. Gunapriya from down south and from Dr. Author of our book, Dr. Sabita Mishra. She will also take around another 5 topics. So we'll cover over 15 topics in the next 2 months, which will have the more clinical relevance as well as very importance in the anatomy subject itself. We also provide the recording of this webinar to all the participants who have provided us their valuable feedback. So from next month, which is going to come very soon, you will please keep checking your emails. We'll be sending the links to join the such sessions of our webinar. I want to thank Dr. Ravi for taking his time out. He has always been very supportive to Wolters Kluwer, and he has written a very fabulous book for us. Which is Snell's Clinical Anatomy, which is now available on the stand and also available on the e-stores.
Thank you so much, sir. And I really apologize for the inconvenience caused in between because of the power shot. I'm extremely sorry for that. So thank you so much. Thanks a lot to all the participants and the Wolters Kluwer for organizing this MedicalEdge series and giving me opportunity to deliver this lecture. Thank you, Mr. Ravi. Thanks a lot. And the Wolters Kluwer team.
Thank you so much, sir. Thank you so much.